it's important you try and prove virtuous triad in order to really fit this picture. So for increased demand, there are things like thyrotoxicosis and myocardial hypertrophy. So for thyrotoxicosis, uh, it's important when you're in the endocrine ward, it's important for you to kind of know how to look for the signs of thyrotoxicosis, like what will they tell you in the history. My friends in endocrinology will be able to take you guys through that. Myocardial hypertrophy, you things like aortic stenosis, big risk factor, and hypertension in adults are big risk factors. But let's say you are in the ward, because I don't know how many of you have been to the CVS ward. How many of you have been to the CVS ward? Hey, could ask Agnes, have you been to the CVS ward?
No, I haven't.
It's okay, it's okay. There's somebody who's raised their hand. Ada, yes, you have.
Yeah, yeah, I've been to the CVS ward.
You're familiar with a young patient called Victor Otieno?
Yeah, I actually clocked him the other day.
Yes, yes. Victor is a very special case of this kind of presentation where there's increased demand. Yeah. You know, in the pediatric population, you have a pediatric male, and with that kind of presentation, you're probably thinking hypertrophic obstructive cardiomyopathy. That's common in that age group. And now you have to look for things like family history of heart disease at a young age. And those are some of the things that tie in your genetics lectures with what you see in the ward. Because I know you guys have covered genetics with Dr. Elovi, and I know she has taken you through Mendelian and non-Mendelian traits. So is hypertrophic obstructive cardiomyopathy inherited in a Mendelian pattern or in a non-Mendelian pattern? Maybe I could ask that.
I think it's Mendelian.
Why do you think it's Mendelian? Agnes, why do you think it's Mendelian?
Can't remember clearly, but I think from the notes it was classified there. I think because it's autosomal dominant or something. Not sure.
Okay, I'm just going to disagree with that a bit. Hypertrophic obstructive cardiomyopathy is non-Mendelian because it's polygenic. It involves a number of genes. You see, with Mendelian traits, they are passed along a specific line you can easily follow. So if you have a patient, they maybe their mother or father or other siblings, then their grandfather. So you can easily trace and you can see that it's a specific gene being involved. But hypertrophic obstructive cardiomyopathy, like diabetes, like hypertension, are polygenic. That's why they are non-Mendelian. Sour. So those are the causes of increased demand. So now let's just talk a bit about the epidemiology of this thing. Ischemic heart disease affects more males than females. That's one thing we have to know. That when you're in the ward, you're clocking an elderly male who came in presenting with chest pain. It's important to quickly clock that this guy could have suffered a consequence of ischemic heart disease. And you have to quickly remember your basic science and remember the process of coronary atherosclerosis. It's really important because, as I've said, cardiology is one of those units where they expect you to know everything because everything has already been taught. Yeah. So you could just be presenting your case and the lecturer stops you. And I remember this happened a lot while I was doing my end of rotation under Dr. Lois, and she would consistently stop and ask the question, why? I don't know how many of you are in 7A, but she really likes that question. So you'll be quickly asked, why, why this, why not that? So it's important to clock in your basic science. So I don't know if anyone is able to describe in Robbins-like detail the formation of an atheromatous plaque and to its rupture, if anyone is able to do that. Daksh Patel, maybe you can try.
Uh, the pathophysiology of coronary atherosclerosis.
Yes.
Okay, so first of all,
Daksh. Well, it appears we've lost Daksh, but that's fine. We can discuss it together. To make this easier, I'm going to divide it into three steps. And there are a lot of details, there's a lot of, platelet-derived growth factor involved, but I'm not going to talk about that. As you're going to talk about, you're going to make it simple, and then you guys will go and fill in the details, yeah? So you have excess fat, and you know the fat that we say is bad, yeah? We say LDL, yeah? Low density lipoprotein. We call it bad cholesterol, and we call high density lipoprotein good cholesterol. You know, that thing is easy to confuse, but if you remember the biochemistry, high density lipoproteins can't be packed into the vessel wall. That's why they're called good cholesterol. It's not they're good because you can eat a lot of them, but they're good because of their structure. They can't be packed into the vessel wall. But low density lipoproteins can, because once again, they are low density. Yeah. So what happens? There's excess fat in your bloodstream. It's just moving around because you've eaten maybe a large meal, and through them it has entered to the mesenteric circulation, and now it's in your bloodstream. Yeah, it's moving all over your bloodstream. So there's a close opposition between the fat and the layers of your blood vessel. And it's important to remember that your blood vessels also have macrophages. Yeah, they have macrophages. And these macrophages are tissue watchmen. Their work is basically to patrol the tissue and ensure that they are not injured. And now, in this scenario, the low density lipoproteins are a threat. Yeah. I know you guys remember the beta lipoproteins. I'm not going to go into that, but the macrophages, they see this cholesterol as a threat. So what they do, they pick it up, and you know how they do it, they engulf. And now you know they're engulfing, they're moving back into the vessel wall. And what happens is these macrophages become now foam cells because they now have LDL inside them, foamy. They become foamy. No foam, white. Inside the body, fat looks white. So that's an easy way to remember it. So now you get the formation of what you call the fatty streak. Yeah. And then the next stage is easy. You are talking about now the formation of the fibroatheroma. Very easy. Now, the foam cells have accumulated within within the intima of the blood vessel. And you know, they normally affect these large arteries. Yeah. I know the layers of arteries. We won't get into that. Yeah. So now this is the intima, and they're there. And now they have invaded this area, and the foam cells are many. So what happens is that there's normally proliferation of smooth muscle cells into the intima. That's what they do. They proliferate, they grow. Yeah. And once that growth happens, the fibroatheroma is formed with a fibrous cap. So there's normally a cap on it, and it's normally stable, and it's a fibrous cap. But then remember, as this plaque is getting bigger and bigger, because not like the cholesterol is going down, because this guy is getting more cholesterol inside, it's getting bigger and bigger and bigger, but the plaque is relatively not changing in size. And the vessel is also not increasing in size. So blood pressure is increasing. And there's something called shear stress. Yeah. it's basically ripping and eating away at the fibrous plaque. And what is happening is that this plaque is becoming, this atheroma is becoming unstable. So it means it can be easily dislodged. Yeah. And that's the pathophysiology, as simple as that. There's a lot of jargon inside, but this is the basic pathophysiology. Another way is that the fibrous cap can be made unstable via inflammation. You know, cigarette is pro-inflammatory. So you smoke, triggers an inflammatory process, fibrous cap off, plaque dislodged. As easy as that. That's what I want you to remember for all intents and purposes of this discussion. So now there are risk factors to ischemic heart disease. They are fixed when you're always thinking about your risk factors, divide them into either fixed or non-modifiable and modifiable risk factors. It makes life easier. So the fixed risk factors are things like age, positive family history, a deletion of the polymorphism in the S gene, the angiotensin converting enzyme. You guys go and read about the role that the S and angiotensin has with atheroma regulation. It's very important. And then you look at the modifiable risk factors, things like hyperlipidemia, cigarette smoking, hypertension, diabetes mellitus, inactivity or living a sedentary lifestyle. You could also have issues with your factors and elevated CRP as seen in infections, things like gout and use of contraception. Yeah. So now let's talk a bit about angina. I don't know, what do you guys remember about stable angina? Maybe I could pick on somebody. Yeah. Barbara?
Um, you guys can hear me, yeah?
Yes, we can.
So stable angina basically is like a short term, it's caused by like partial obstruction of the coronary artery, and it occurs on exertion, like during exercise or emotional distress, stuff like that.
Okay, that's good. That's good. That's good. Brinda Patel, what do you remember about unstable angina?
That's like chest pain that happens even at rest, because because the plaque is like occluded by a thrombus or an embolus. Yeah.
That's good. That's good. That's good. Thank you so much, Brinda. Chandra Puja, what do you remember about Prince mental angina?
I think Prince's mental angina was caused due to like spasming or narrowing of the artery, the coronary artery, and not related to stress.
Thank you so much. Thank you. Thank you. That's true. So for Prince mental angina, I want you guys to remember the sympathomimetics. So things like cocaine, things like methamphetamines, they're important. They're important causes of Prince mental angina. That's why we ask them in the history. So let's move to the next slide. So let's talk about acute coronary syndromes. Yeah. In the word, avoid as much as possible saying my diagnosis is a myocardial infarction. Yeah. Maybe I could ask, what is an infarct? What is an infarct? What is an infarct? Yasmin, are you in a position to tell us what an infarct is?
Yes.
Yes.
An infarction is where like the tissue lacks blood supply and then the tissue dies.
Yeah.
Yeah.
When you're explaining, I want you to replace death with irreversible cell injury. Yeah. Because we know now, start saying cell injury, cell death, they'll be like, okay, try and as much as possible to use the terms that are in those big books of pathology to describe some things because they'll ask these questions. So when you're in the ward, you had a patient and you're so sure and you're like, wow, this is textbook myocardial infarction. Watch out because number one, in the ward, particularly in internal medicine, even in other disciplines like surgery, there's what is called a diagnostic criteria. Yeah. You don't just scream conditions when they come. Conditions have diagnostic criteria. Last week, were you guys taken through, Ida, were you guys taken through heart failure with Adnan?
I'm not sure.
Okay. So if Adnan had taken you guys through heart failure, there's something called Framingham's criteria, which is a diagnostic criteria in heart failure. And anytime you're presenting a heart failure patient and you're like, my patient, I'm positive as hell that this guy has heart failure. The question will always be asked, show me diagnostic criteria. Where is the diagnostic criteria in your history? Yeah. So don't scream myocardial infarction because myocardial infarction has a very particular diagnostic criteria. Yeah. Diagnostic criteria is they have a rise or fall of cardiac biomarkers values with at least one above the 99th percentile upper range limit and with one of the following. So it's either symptoms of ischemia, new or presumed ST changes, pathological Q waves, imaging evidence of new loss of viable myocardium or new regional wall motion abnormality. Then there's identification of an intracoronary thrombus by angiography or postmortem. That's a diagnostic criteria. Yeah. So you don't scream, am I, am I? When you have a patient with the classic symptoms, try and use the word acute coronary syndrome. And just to make you aware, acute coronary syndrome involves both myocardial infarctions and angina, in particular, unstable angina. So you have to know that the difference between angina and the non-STEMI myocardial infarction is due to there's a change in cardiac biomarkers. In unstable angina, there's normally no change, but in non-STEMI, there's a change in cardiac biomarkers. So you have to remember that the pathogenesis of acute coronary syndrome is related to the rupture of an unstable atheromatous plaque. And I hope you guys are aware of the complications of a myocardial infarction. And maybe we'll do it a bit more practically. And we have a small exercise. Maybe I can just move to the next so that it can really quick click. Let me just stop share a bit. So we're going to do a sample history, and I'm the one who's going to present this history. So let's remain keen. So I'm presenting GR, a 59-year-old man who has been living in Langata for the past 30 years, and he's a businessman by occupation. He was admitted 4 days ago. Patient is a known hypertensive, diagnosed 20 years ago on enalapril, and reports adherence to his medication. The patient came in presenting with a 2-day history of chest pain, a 2-day history of difficulty in breathing. The patient was relatively well until 6 days ago when he reports experiencing chest pain that went on for 2 days. The chest pain was central, sudden in onset, and he described it as crushing. It was radiating to the left jaw, and it was present throughout the day. The patient reports initially it was exacerbated by exertion and relieved by rest. However, 1 day later, the patient reports experiencing the chest pain even at rest. He grades it between 6 to 8 on a scale of 0 to 10. And the patient reports an associated feeling of impending doom and reports an associated increased awareness of the heartbeat, which he describes as fast and irregular. He described it as fast and irregular. And he reports an associated increase in increased sweating. And the patient has no history of trauma, no fever, no cough, or any change in swallowing. The patient reports a 2-day history of difficulty in breathing that occurred suddenly. Initially, the patient reports it was present on exertion, suggestive of New York Heart Association grade 2 dyspnea. However, 1 day later, the patient reports experiencing the symptom even at rest, suggestive of grade 4 New York Heart Association dyspnea. The patient reports that initially it was exacerbated by exertion and relieved by rest. However, one day later, the patient reports experiencing the symptom even at rest. Patient reports that the symptom was present throughout the day, and the patient reports that it interferes with his activities of daily living, such as working, cooking, and cleaning. The patient also reports an associated feeling of difficulty in breathing upon lying flat, suggestive of orthopnea, and the patient reports an associated feeling of waking up gasping for air, suggestive of paroxysmal nocturnal dyspnea. The patient confirms that he had no night sweats and no weight loss. However, the patient reports 2 months ago he experienced a moment of loss of function on the right side of the body that lasted for 12 hours. It occurred suddenly, and the patient reports that it was non-progressive. It had no exacerbating or relieving factors, and it was present throughout the day and went away on its own. Patient reports that it interfered with his activities of daily living, such as walking and talking. The patient reports an associated feeling of drooling, difficulty speaking. The patient reports that he could not swallow. He confirms that he had no history of trauma, no headache, no tinnitus, no vertigo, no loss of consciousness, no dizziness, and no change in any of the 5 senses. The patient confirms that he experienced no abdominal pain, no jaundice, no abdominal distension, no change in bowel movements or habits. And the patient reports that he had no generalized body swellings, no change in urine output or frequency. Patient confirms that he had no dysuria, no oliguria, or any anuria. The patient confirms that he had no joint pain or aches, and he confirms that he had no rashes. The patient, however, reports that he has a history of past alcohol use. He stopped 12 years ago. Initially used to consume 10 units per day. The patient reports a positive history of cigarette smoking that he has since stopped, that he stopped 12 years ago as well, where he used to average at roughly 10 pack years. Patient reports a family history of heart disease. He says that both his parents are hypertensive. Patient, however, reports no history of IV drug use or any use of cat, cocaine, or methamphetamines. The patient reports, however, a sedentary lifestyle and a fat-filled diet consisting of fried potatoes and pork. So the patient was rushed to Kenyatta, where he was given supplemental oxygen, and IV drugs were given, and blood was drawn. Imaging has since been done, and the patient is awaiting for the results. Currently, the patient reports that the symptoms have subsided. Okay, let me ask, what do you think about this history so far? Any questions concerning this history?
I have a question.
Yes, Agnes?
So I'm not sure if I missed anything, but I remember there's a Dr. Lois told us that when you presenting your patient, I'm not sure if like this is a specific system, but when you're doing your HPI, you do the review of systems that is associated with like the presenting illness, and then like you'll do the other systems that are not associated and probably have negatives at at the end, like where we normally do the ROS. So I was just wondering, like for the, I think GIT and the urinary system, maybe you can just clarify why you put them in your HPI.
Okay, Agnes, thank you so much for the question. Maybe I could pose a question to the guys. Why do you think I've added the GI symptoms there? Why do you think I've added the GI symptoms there? Yes, Ida?
Because sometimes a patient with a condition like GERD will also present with chest pain.
Yes, that's true. What other reason is why GI is there? Because that explains why I asked about any abdominal pain, but it doesn't explain why I asked about jaundice.
Yeah, true. Okay.
Pooja, why do you think I asked? Chandra, why do you think I asked?
Um, maybe like to try to rule out any like heart failure. So if
Thank you.
there's right-sided heart failure. Yeah.
Thank you so much. Thank you so much. Thank you so much, Peter. That's exactly why I asked. Agnes, are you with us still?
I'm listening.
I know. I was examined by Dr. Lois, by the way. I could tell you for free. She asks the question why a lot, and I appreciate that you've asked it. So let me take you through my train of thought one by one, yeah? So we're going to start from the top. This should also help us kind of review how to take a history. So anytime I have something before me, I use this. Are you guys familiar with this? Can you see my screen if you've seen what I've written?
Yeah, we can see.
We can see.
You guys are familiar with this formula?
Yeah. Yes.
Yes. So this is how I come up with my list of differentials, yeah? So now we're going to think of indicate always as we go through our history slowly by slowly, yeah? So number one, we're going to highlight the risk factors as we continue. So up here, what do you think is the risk factor? What do you think are the risk factors present up here that can help you come up with a diagnosis?
Oh, wait, sorry. I'm not familiar. What is vindicate?
Now we're going to go through it. Maybe I could do it right now. It's not being lazy. All right, so vindicate is how you come up with differentials, yeah? So V is for vascular. Let me do it down. It makes much more sense. So V stands for vascular. So V stands for vascular. So V is for vascular. I hope you guys will be able to just imply that V is for vascular. I is for infectious. N is for neoplastic. D is for drugs or degenerative. I is for iatrogenic, doctor-induced cause. C is for congenital. A is for autoimmune. T is for toxins. E is for environment or endocrine. I hope that has answered your question. This is how we're going to come up with differentials. This is how you come up with differentials, yeah? Use the mnemonic video.
Yeah.
I'll explain it as we continue, yeah? So up here in the biodata, what do you think the risk factors are, guys?
Can you see?
I'm sorry.
Yeah, I've seen the chart. I've seen Ida has said he's a man, his age, and he's living with hypertension. That's good. Number one, when you're describing the comorbidities, you guys like to use a word called compliance. What is compliance? Can anyone answer what compliance is?
Adherence to their medication or
Compliance.
like when you're okay.
Compliance in medicine is a laboratory value. It's a value you obtain after a test. Yeah. To check for the compliance of diabetes, you do HbA1c. To check for the compliance of antihypertensive drugs, you check for ambulatory blood pressure readings. Yeah. So you use the word adherence. He can adhere. Whether he's compliant or not is up to the tests to prove. So use the word adherence. some people really get ticked off. I'm going to tell you for free. Some of them get really ticked off when you say some things like when when you start presenting your history and you are on the wrong foot from things like adherence and compliance, you're fighting to get to a 50 already. It's a very subjective exam, guys, and you have to be aware of that there's no standard system of judging. They're going to judge you according to how they feel, and it's going to be unfair, but you have to ensure you mitigate all the circumstances that can fall on you. Like anything that you can encounter, you have to mitigate the risk. Yeah. So avoid using things like compliance. Adherence is the term. Yeah. Sawa. So let's come to the presenting complaint. What in the presenting complaint can give you a clue as to what you think it is? Guys, this is a game where we're literally actual detectives. So tell me, what in the presenting complaint? Yeah, the acute symptoms. Thank you so much. And guys, if you have just an answer, just unmute. We are not in class. So the acute presentations. So already when you've started, we have a clear picture of what is coming. So now, patient was relatively well. Note that I've not used stable. I've used relatively well. Why do you think I've used relatively well and not stable? I would like to pass this question to Ida. Ida, why do you think I've used relatively well and not stable? Because I've read your history and I know you like it, the word stable.
Is it because of the hypertension?
No, when you tell me you are stable, what is stability in medicine? This is semantics, guys. This is semantics. Yeah. History is not what it has, it's how you will package it. So when you say the patient was stable, okay, so he was stable. What are the parameters of hemodynamic stability? Have you anyone here knows? I think I will ask Barbara this because Barbara, you're in surgery. What are the parameters of hemodynamic stability?
Some criteria is like blood pressure, heart rate, urine output, capillary refill.
Thank you. Thank you so much. So you started saying the patient was stable. They look and they say, okay, stable. So this person has seen the lab values. So what were the values? People like Prof Amaya will just straight up ask you. So what was his HB at? What was the blood pressure? The last blood pressure reading, urinary output, because those are the criteria for stability in medicine is that. So you don't say stable. Semantics, guys. Use things that are conservative. So patient was relatively well, meaning that he had a chronic condition, so he can't be completely well. He has hypertension, he's living with hypertension. So of course he's not well. So he was relatively well. Relative to his condition, he was okay. Yeah. And then last well, he had no comorbidity, he was okay. I hope you guys are following me. Brenda Patel, are we together?
Yes.
Okay. So, or somebody asked, what are the significance of the acute symptoms? Because the presentation of what we think this guy has is acute. That's why it's called acute coronary syndromes, yeah? Okay, sorry guys, I hear I'm breaking. I hope you guys can hear me now.
Yes.
Okay, all right. Sawa, we've talked about relatively well. So we are fixing this semantics. So, and the patient reports experiencing chest pain that went on for 2 days. So 6 days ago, because he was admitted 4 days ago to the time that you're clocking. Yeah. Once again, be very keen. This is how some lecturers, like the one that Agnes has just mentioned, have very, very, I don't know, I want to call them very off pet peeves. Like they get ticked off by the smallest things. She could get ticked off by how you enter that room, trust me. So you want to avoid this. And how do you avoid this? You have to be cognizant of some things, like when did you clock the patient relative to when they were admitted, before you start saying patient was relatively well until 2 days ago and she's lost. Yeah. And now, what else in this pay about this chest pain do you think is telling? Please unmute and speak, or maybe I could pick on one person. Chandra, could you tell us what about the chest pain do you find telling?
So, first of all, it's central, and then sudden, so like the acute part of it. And the crushing, actually everything. So like crushing and radiating to the left jaw, and it being on the left side, constant. So maybe we could have asked how many minutes, because we know unstable angina, I think, lasts more than 20 minutes. And yeah, exacerbated by exertion. So we know it's pain on exertion, relieved by rest. So, okay, so we know it's not pain on rest. But then, yeah, 1 day later, it's progressed to pain on rest. And I think you had mentioned sweating later on. Yeah, so it's pointing towards the acute coronary syndrome.
Thank you, Chandra. So I want to correct a couple of things from the mistakes that are commonly made at this stage when you're describing the symptoms. The mistake number one you're more likely to make is putting the associated symptom in between your history. So like I know Socrates, it follows like that, and it's tempting to just do it like R, then the associated factors. Yeah, it's very tempting, but avoid putting the associates smack in the middle. Why do you think that is? Maybe I could ask Agnes, because Agnes has interacted with Doc. Agnes, why do you think you should avoid that?
Honestly, I'm not sure.
You should avoid that because if you pack your associated symptoms smack in the middle, you are at risk of, you will find something positive, you go on and you describe it, and then you're going back to the chest pain. Why? It makes, you see, there's no sense over there, yeah? Because you guys have to remember that history taking is an art as it is a science. So you balance your knowledge of English with your medical knowledge, yeah? So if you look at the structure of this sentence, you guys remember in English, there was this thing that you could do when you're addressing, when you're referencing a point and you have something that's irrelevant, you could use 2 commas. But then this is too long for the 2 commas, yeah? So somebody who's listening gets thrown off. So like Mara, we were at no change in swallowing, and now we are in, we're back to chest pain was present at rest. What is happening? Yeah. So you should try as much as possible to avoid. And then there's another common mistake that is done. And even us, when we started, we used to make this mistake. I've told you guys, when I say read Hutchison's, I'm not saying you go read, I don't know this guy, what's this guy's name? The Mossab notes or something. Those notes, those short notes. Don't go there. I've said you go and read Hutchison's. There's a reason why I'm saying go read Hutchison's. If you look at chest pain in Hutchison's, and we talked about this when I was introducing, taking the cardiovascular history, and we talked about chest pain. Chest pain in Hutchison's only has so many relevant associations. You remember what I said? Socrates, so you start with a systematic analysis of symptoms. Those are the 6 things that have to be in your HPI. Systematic analysis of symptoms. Then number 2, relevant associations, what you do with the A in Socrates and operates. So relevant being the keyword, relevant associations, yeah? So why do you think I asked about this associated feeling of impending feeling of doom? It has a name, by the way. It has a very fancy Latin name. But why do you think I asked about it? Maybe I could go and inquire. Is it AJ? I don't know. I don't know how to pronounce it, so I don't want to butcher it. But if you could please, yeah?
I'm not sure, to be honest.
It's okay, it's okay, it's okay. So there's a feeling, it's called angor animi, the feeling of death. It's associated with the acute coronary syndrome. They feel like they're going to die. And that is a symptom that is medically accepted. And it's telling, yeah? It's not journaling. One thing you should avoid in your history is don't journal. And I'll tell you where people journal. Because you used to journal as well. So yeah, so there's that feeling. So the relevant associations of chest pain, we divide chest pain into their causes. I said chest pain could be musculoskeletal. I said chest pain could be cause of the thoracic esophagus that is in the posterior mediastinum. I said chest pain could be respiratory. I said chest pain could be cardiovascular. And those are the relevant questions you ask in the associations. Yeah. So cardiac, what is telling me that it's a cardiac problem is the fact that there's this impending feeling of doom. There's an increased awareness of heartbeat, and he described it as fast and irregular. And there's this increased sweating, which is called diaphoresis. And then now you see, this is telling me that it's cardiac. So how didn't I know it's not musculoskeletal? Number one, it's not musculoskeletal because it has no relationship to his position. Yeah. It is not generalized. Yeah. It is at one point. Yeah. How do I know it's not musculoskeletal? Because he tells me there's no history of trauma. Yeah. There is no fever or hotness of body is telling me that it's not both musculoskeletal, because there are things like costochondritis that have fevers, and could be things like respiratory, like pneumonia that has fever. And there's no cough, removing the resp portion for me. And there's no change in swallowing, removing the GI component, because the thoracic esophagus is there. Yeah. I hope you guys are with me. Agnes, are you with me?
Yes, we are.
Thank you. So those are relevant associations. It's normally very off. I just want to be real. It's off. And if it's off with us, trust me, because it's more irritating. When you say some things associated with some things, and they look at you like, okay, so this one has not read Hutchison. Some notes said, don't go read Masaub notes right now. This is not the time for Masaub notes. The time is coming. Right now is go and devour that Hutchison. Understand those relevant associations, those paragraphs. Actually, the first like 6 pages of each chapter before you start the exam are more important than the exam itself. I'll tell you why. The exam itself you can learn on the fly, but those subtle things in history can't be taught. You have to practice them all the time. Yeah. So now we have this next symptom: 2-day history of difficulty in breathing that occurred suddenly. And you guys, now how I described progression, this is another place right here where we talked about progression. Where we talked about progression is most people normally say progressive and leave it at that. And so why is it there? Oh, progressive, how? How is it progressive? As much as possible, let your history answer every question you expect to be asked. Yeah. So initially, this is how you will say progression in difficulty in breathing. And note, I have not said shortness of breath. I have not said breathlessness. I have said difficulty in breathing. And I'm going to explain this because there are guys among us who aren't with us. In cardiac history, when you have a patient with a cardiac picture, it's difficulty in breathing. Why? Because it's not about increased work of breathing. If you guys remember from physiology, breathing is passive unless there's an obstruction or a restriction. Then breathing becomes active, respiration becomes active, meaning that you'll now use the accessory muscles of respiration and the likes. Yeah. But this is about increased alveolar diffusion gradient. Yeah. So I want you to always, in your mind, I don't know, I'm going to draw something outlandish, but hopefully you'll get the idea. So imagine whatever I've drawn here to be the lung vascular bed. Yeah. So this is, we've taken the alveolar, we've zoomed in on it. Yeah. The alveolus. And we have the lung parenchyma around it. We have that beautiful membrane at the end. So we have the heart, the lung has a very interesting vasculature. At the bed, it has both venous and arterial. Yeah. And then there's the interstitium around it, this big thingy. We're going to put it around. This is called the interstitium. So now they normally operate by the fact that the veins are low pressure system. The venous system is low pressure. And then the arterial system is high pressure. And equilibrium is maintained like this. Equilibrium is maintained because the low pressure, high pressure cancels out. Yeah. So now, normally in heart diseases, and since you've not done heart failure with Adnan, I'm not sure, but low pressure and high pressure has to be balanced throughout. So in a scenario, there's an increase in pressure, like let's say because the pulmonary vein is from the left side of the heart, if there is increased pressure more than usual from the left side of the heart, because the lung bed is very unique. Normally that venous pressure from the left heart is a bit too high than normal venous pressure, but because the lung is unique and isolate from other systems in the body, it doesn't know that. Yeah. So what it knows is that this is normal pressure from the left heart. So in left heart failure, when there's an increase in venous, in pressure system in the left side of the heart, what happens is this venous pressure increases. So because this venous pressure increases, there's no longer an equilibrium. Equilibrium is gone. So fluid is forced into the interstitium, causing a phenomenon called pulmonary edema. Yeah. So that causes difficulty in breathing because the interstitium is swelling. The lung is filling with water and it is swelling, meaning that what you can't do is that diffusion won't be effective because the diffusion gradient has increased. The work of diffusion has increased. So that is difficulty in breathing. Shortness of breath, there is increased work of breathing. So respiration is passive until there's restriction or obstruction. So in restriction or obstruction, the patient starts now breathing funnily. There are things like Kussmaul's breathing, use of accessory intercostal muscles, those things, they occur in resp. But here is difficulty in breathing. So note that I've used difficulty in breathing. So in presenting a cardiac history, use difficulty in breathing. On exertion, initially, suggestive of...
I have a question.
Yes, Agnes.
Sorry to interrupt.
Yes.
Like both of these, the shortness of breath and difficulty in breathing, both clinically referred to as dyspnea. Dyspnea is just the difficulty in breathing.
Yes, both of them medically are referred to as dyspnea. It's just the etiology that's different. Yeah. And even their classification, because shortness of breath, the dyspnea from resp, is normally classified using the Medical Research Council grading of dyspnea, or MRC for short. All this is in Hutchinson's. While the difficulty in breathing that is cardiac, or dyspnea that's cardiac dyspnea, is normally classified using the New York Heart Association, yeah, classification of dyspnea. So when you're tailoring your history, you want to look good. You want to look like somebody who knows how to communicate. So patient reports initially, the feeling was present on exertion. However, suggestive of New York Heart Association grade 2 dyspnea. However, one day later, the patient reports a symptom being present at rest, suggestive of New York Heart Association grade 4 dyspnea. Note, I have not said NYHA. I have not just said was on exertion. NYHA grade 2. No, I've said suggestive. Yeah. Suggestive implies it is open for disapproval. Semantics, guys. Suggestive. Now, we start really going through the physical and the systemic exam, I'll tell you how to now say it. You now, when you're seeing the patient and the patient was undressing or breathless even at rest, you'll now say NYHA grade 4 dyspnea confirmed. Patient is the dyspneic even at rest. Yeah, that is an observation. That's how you confirm it. Yeah. Any question up until that point? Okay, there's no question. So this one is done. The A, I did this on purpose because I just wanted us to go through a bit of, like, you should put it at the end so that you don't refer, but then we've already talked about that. And once again, difficulty in breathing is not associated with a cough. It is not associated with chest pain. It is on its own, or shortness of breath for that matter. The rest guys will take you through that one. I don't want to touch that one. But difficulty in breathing is only associated, dyspnea is only associated by two things. Normally, what we've described is exertional dyspnea. So exertional dyspnea is associated with two things. It's either orthopnea, difficulty in breathing when lying flat, or paroxysmal nocturnal dyspnea. Anything else is not a relevant association of difficulty in breathing, yeah? Then this one was okay, constant interferes with activities of daily living. So now let's come to Agnes's question. So Agnes, I'll need you unmuted for this. Please unmute.
Okay.
No, I'm not attacking you. It's not a threat. It's not a threat.
Okay.
It's not a threat. Why do you think I asked this two for these two?
Hey. Okay, I know night sweats na weight loss are usually associated with malignancy, but I'm not sure for this case.
You're okay.
Or
Malignancy
TB.
or TB.
Or
Thank you.
TB because of the
Thank you. That's why I asked that question. Yeah. So when we get to this level, so when you start thinking about your important positives and negatives, you should have your vindicate in your head. Okay. AJ, can you hear me? I hope, because this is where you had asked me, if I can remember correctly.
Yeah, I can.
So when you get to this level, you have a clear picture in mind. So the question you're trying to answer is why, and why is this occurring like this? And is it due to this or is it due to that? So now let's put vindicate to the test. Let me see if I can move this thing here. Let's put vindicate to the test. So far, with what we know, and you see anything you ask on important positives and negatives, it shows it's an inquiry into, it's a peer into your differential thinking. Yeah. So vascular, what do you think are the vascular causes of what this guy has? Because those ones we discussed up there because they're relevant to the presenting. But what are the vascular causes that you think that have caused this guy to have this? And how have I ruled them out or in? Patient had chest pain and dyspnea, guys. What are the possible causes? Yes, Ida?
Sean, before we continue,
Yes.
I wanted to confirm something.
Yes.
Do you indicate per symptom, or you bring them together and then you indicate from there?
Yeah, you've indicated what you've brought them all together. I want to explain this in a way that makes sense. You see, for chest pain, why I said that medicine is very semantic. It's about semantics. So note that when you're doing your presenting complaint, the word relevant associations, relevant being key. And I've explained to you why each and every time I was asking in my symptom, I asked this and this, because chest pain can be directly caused by either of those issues, yeah? And then difficulty in breathing as well. I did that because there's difficulty in breathing that's very associated with that is not associated with orthopnea or PND, the shortness of breath. Most of the time, it's not associated with orthopnea or PND. Yeah. So I hope I've made sense, Ida.
Yes, thank you.
So let's continue. So what, guys? You guys did patho. So what causes chest pain and what are the vascular causes of chest pain and difficulty in breathing?
I know chest pain could possibly be an aortic dissection, but that one radiates to the back, so I'm not sure.
Thank you. So that was also in our thinking when we started. But because up here, we ruled it out by the fact that it is radiating to the left jaw, and it's not tearing, it's crashing. This is how you give your differential. It's actually done a good job, AJ. When you're told to give an impression is what you most likely think. When you're told to give, because Dr. Sheikh will tell you give 10 to 12 differentials, yeah? You don't say that because in my history I didn't know. How did you not see, and how can you explain how you got to that point? Yeah. So you've told me exactly that an aortic dissection could be a cause. So another vascular cause of chest pain and difficulty in breathing.
Can you, sorry.
Mm-hmm.
An aortic aneurysm.
Why would it not be an aortic aneurysm? Actually, that has given me a question that I forgot to ask, but okay. We're learning. How would you ask an aortic aneurysm? What are the causes of aortic aneurysm? And how does because you see, it's very interesting. AJ has talked about aortic dissection, and then you brought in aortic aneurysm. The presentation is somewhat similar. But then I will tell you how you'd ask about an aortic aneurysm. Are you guys okay? Let me see something in the chat. Lovely, lovely, lovely. Somebody has said it in the chat. Syphilis or Marfan's. So you'll ask about a painless sore on the genitalia because of syphilitic root aortic aneurysm. Marfan's is congenital. So if they have an aneurysm in the aorta, it probably would have been they've had a brain aneurysm before. They've had an aneurysm of the around the spine. So it's very important. Thank you. Thank you so much, Irak. Thank you. So yeah, another vascular cause of chest pain and difficulty in breathing. Very easy one. You guys are passing up.
Can you say pulmonary embolism?
Lovely. Then we'll talk about how I rule them out. Very nice, very nice, very nice. Another cause, and that is our topic for the day. Somebody, let me see
I
what.
think someone had said it, an acute coronary syndrome.
Yes, yes, yes. Hirak, thank you. But what you've said will be an infectious cause. I'm getting to it. So yes, yes, yes. So for infectious, I'm going to give you guys clues. So infectious, it could be TB, it could be pneumonia, it could be rheumatic heart disease. Yeah. It could also be, there's another one, but this one is not in adults. Don't make the mistake I did. I started screaming Koksaki when I was in with Lois, and it was a very interesting time. There's also something vascular we've forgotten, but we'll put it under autoimmune. So for neoplasia, chest pain, so many. So we just put neoplasia, you don't get specific unless, because you start saying atrial myxoma, you will sing atrial myxoma, my friend. You will be told to say, where is atrial myxoma found? So try and avoid as much as possible to say things like that. So, but neoplasia, it's neoplasia. Could be malignancy. That's what you say. And you just ask malignancies also. Then if they get specific, you could now cook atrial myxoma or bronchogenic carcinoma. This guy is a man, and atrial myxoma is unlikely. Maybe a thymoma due to a lymphoma. I hope I'm not speaking Greek. I hope we're making sense with each other. Agnes, we are together? Is Agnes with us? Okay, I hope we're together. In case of anything, just communicate in the chat. And then for drugs, which drugs would cause chest pain and difficulty in breathing? I'm going to give you guys a clue because we don't have the time to talk about pharmacology. All right.
Can you say cocaine?
Yeah, cocaine. Okay. Another one could be alcohol. Alcohol.
Does doxorubicin count because it causes dilated cardiomyopathy?
Thank you very much. Thank you very much. I was looking for that one. I wanted to give you the clue, the cancer one in Dr. Kubo's notes. So there's doxo and another one. There's so many drugs. There's cat, there's cigarettes, there's what else? There's meth, amphetamines. Yeah. So iatrogenic, what can a doctor do that will cause chest pain and difficulty in breathing?
Maybe like a pacemaker surgery coming on.
Yeah. Brenda, was that you? I couldn't hear you for a moment. Barbara, since you're in surgery, what have you seen doctors do on the chest? That's very important. That can cause chest pain and difficulty in breathing.
Honestly, apart from the surgery itself, I'm not sure.
Chest tube insertion.
Oh,
The chest tube, he has chest tube, so it's important. And it's normally, these are the things that are really embarrassing when now you've cooked a history, because we are somewhat, I consider myself a chef for all intents and purposes of history. So sometimes you're there and you're cooking your history. 59-year-old guy, you've cooked, you think you're good. You go up there, you present your case. Like, when you just hear the word daktari or doctor, are you aware the patient had a chest tube? Eh. And then now you're fighting for your life. So these are important things. Have you had any procedures? Any chest tube insertion, any surgery, any bronchoscopy? Very important. Then congenital. Wow. Then congenital. Somebody has talked to me about Marfan's. Congenital are many. I'm going to put them together as congenital heart diseases. And guys, go read up on them and their risk factors. So when you're clocking Victor Otieno, a patient in 7C, and you have not inquired whether his mom smokes or drinks, or his dad smokes or drinks, if his mom was diabetic, if if when pregnant his mom, where she used to work, because he's an older kid, he's like maybe 14, 13, he remembers a lot of these things. So you can ask him. And if you don't ask him, they're like, okay, this person hasn't read congenital heart disease and clearly doesn't know the risk factors. And that's how you start fighting for your life, yeah? So congenital, there's the congenital heart disease, there's even things like Marfan's. Autoimmune, there's something in autoimmune. Give me things in autoimmune that can cause this. Very easy things.
SLE.
Oh, lovely.
Can you also say rheumatoid arthritis, because it can also have systemic,
Okay.
like, I don't know.
What else in autoimmune? You guys remember something called Takayasu? Let me call it Takayasu. And it's a large cell vasculitis. And there's something called Kawasaki. I hope I've not lost you guys because I know who taught this lecture in pathology. So I know it could be easy to lose you guys, but are we together? Are you guys familiar with these ones?
Yeah.
Okay, lovely. So toxins, give me bad toxins for the heart. When in doubt, just say lead or heavy metals. You can cook up a lot of things on toxins, yeah, but lead is normally the most prominent. Lead exposure. It's because it's a dense metal, it deposits everywhere. Then endocrine, or in endocrine, to me, what's important? Diabetes.
Thyroid disorder.
Yeah, thyroid disorder. Thank you. Thyroid. Then what else? There's something so interesting that you're leaving out. So interesting. So it's such a lovely thing. And it also explains why I asked GI symptoms. Pew. Right, and we're done. This is how you use Vindicate. So Vindicate will guide you. So now you come here to this question I asked you. Is anybody aware why I asked about CNS symptoms? And what I was proving?
Can you say a TIA?
Lovely. Thank you so much. It's a TIA, transient ischemic attack. It's an important risk factor. Anybody who's had, if you've had a thrombotic event elsewhere in the body, it's important because it's a risk factor for acute coronary syndrome. So I asked this because of a TIA, and this is how I asked it. It describes loss of function 2 months ago, went away on its own, and it lasted for 12 hours. Any question up until this point? So the reason I asked this is that it justifies my impression. And what do you guys think my impression is? I had Hirak had said a plural tab. That's actually really nice. Justifies my impression, and my impression is that this guy has an ACS, has an acute coronary syndrome. So yeah, so this is justification of my impression. And now, this one's here, because you've touched a CNS question, you have to finish with CNS in entirety, yeah? If I found anything positive here, especially here, this would have been very telling. But my friends in neurology, when they take you through strokes and the various types of strokes, these two could still justify my my thoughts. But my friends in CNS, I'll let them have this one, because if we start talking about this one, we'll never finish. So these two, let's go and read them why vertigo and change in 5 senses is important to me. So GIT, you've been told one reason I asked. Two reasons actually. Ida talked about JAD. So I was saying no JAD because it's not JAD. And then somebody talked about RHF, right heart failure. Now I'm going to bring you one more. You guys should be familiar with FEO. Yeah? Yeah, thank you. I've just seen acute coronary syndrome. Guys, go and increase your familiarity with pheochromocytoma. Pheochromocytoma is normally caused by an adrenaline secreting tumor. and they are not limited to the adrenal glands. They are normally actually extra adrenal gland secreting sites. Could be because of the ones in the chest, could be a tumor in the abdomen. That's why a CT scan is normally first line in view. So just know that's also another reason I asked. Agnes, are you with us? This is why I need you to stay ready. Okay, so I'll assume she's with us, and I'll continue. So renal, why do you guys think I asked renal? Why do you guys think I asked renal? I'm going to give you one word that's going to save you anytime you're put in the spot that I've just put you. So call it end organ damage. Don't misuse this phrase though. And why do you guys think I asked about this? These two.
Were you trying to rule out rheumatic heart disease?
That's one. Another one.
The SLE.
Thank you.
Autoimmune.
Any of the other vasculitides? Yeah, all of them have a similar presentation. They involve a rash and they'll have joint pain. And there's also something I was saying for that's a complication of hypertension. Yeah, and it's called peripheral arterial disease. You guys remember intermittent claudication? I hope you guys do. In the integumentary system, any rashes, any skin color change is very important because of peripheral artery disease. Yeah, then this one is obvious. Anyone has a question here? So now I'm going to tell you guys, because this is where I wanted to just highlight something before we close out. Or Kwanzaa, does anyone have a history to present? We do it within time. But okay, before we get to that, let me just tell you where the mistake is made here. So here, the mistake that is made is journaling. So I've said the patient reports a history of alcohol use 12, and he stopped 12 years ago and he was averaging at 10 units per day. The mistake most people make is, so GR reports a history of alcohol use and says he used to drink with his friend in UK 12 years ago, and they used to average at 10 units per day. It's very annoying to them, actually. They be clear, precise, straight to the point. Yeah. And then, because risk factors have behavior, so family history important, drug history important, the lifestyle, the sedentary lifestyle. And why I put this there is that number one, the notes should be something to guide you. Describe that sedentary lifestyle. You have to say the patient does not engage in any exercise activity and has a high fat filled diet. That is what consists of sedentary lifestyle. And then you describe the medical contact and the current status. Those ones are easy. Any question till that point? Yes, Ida?
So I have a question, not on the presentation today, but like I usually find it difficult when a patient has had like multiple hospital visits. The same, I mean, I find it hard like fitting that into my history. Like let's say for example, the other day I was collecting a patient who has been going to another hospital for the same condition, but they were not improving. And then they went to Mbagathi and then they were referred to KNH. Do I need to mention the fact that they had gone to those other hospitals, but they were not improving
Yes,
in
yes,
my
yes.
history.
Yes, it's very important. And I'm going to tell you why it's
So
important. Yeah?
at what point do I fit that into my history?
You saw what I've said about rush to KNH and everything and that sorts. Number one, you have two opportunities to present this. The first, and I'd suggest if it's related to the presenting issue, use the first opportunity. The most important risk factor of all is a history of similar symptoms in the past. Yeah? So what you'll say is the patient reports a positive history of similar symptoms in the past that resulted in admissions at peripheral facilities within this and this years and given this and this medication and has not improved or had or improved and then relapsed. Yeah. I hope that makes sense.
Yeah,
Brief,
it does.
simple, clear, straight to the point. That is what they want. Don't journal. You see, now the problem will come when you start saying, so 2 months ago, patient admitted and Baghdadi came in with 1, 2, 3, too long, you get into it and you deviate from what is wise now here. Yeah. But it's important to highlight those admissions because you must be talking about the progression, the pathophysiology. So is it related to this pathophysiology? Yeah. I hope that was anytime. So now we're going to run over this quickly. So your patient has come to you and they have an acute coronary syndrome. What investigations would you conduct for that? Let's make this a discussion since you guys are familiar with the pathology. So let me give you guys a trick. Chandra, as you answer, just a moment. Let me give you guys a trick. When you're presenting and you stay, nobody tells you to give your impression and differentials, but they want you to. They want you to fight for yourself. So don't finish presenting your history and then just keep quiet. Let them tell you to keep quiet. Don't keep quiet by your own volition. Don't go and you start saying and you keep quiet. No, say everything. Say my impression is the patient had an acute coronary syndrome. Actually, this case that I presented, it has a unique impression, but that is not our discussion today. But the impression on average is an acute coronary syndrome. And my differentials are as follows: pulmonary embolism, aortic dissection, aortic aneurysm, yeah, malignancy. And then you now talk about maybe coronary artery disease secondary to cigarette use. Yeah. So now you talk about all those other things. And then now you will say the investigations that I will order for my patients are for his labs. You see, labs. I've started with labs. Labs. In labs, you start with the most important thing. The least diagnostic to the most diagnostic. Yeah. Least invasive, most invasive. So number one, complete blood count. What do you expect to see in complete blood count? So what do you guys expect to see in a complete blood count, by the way? Of somebody with an acute coronary syndrome?
There could be anemia. Sure.
Not exactly.
I'm not sure, but probably monocytes would be high.
Okay, maybe. But there's one I'm looking for, the most important one. Which one do you think will be high? There are two things, and they are markers of inflammation.
Oh, CRP and
ESR.
ESR.
Yeah, thank you. ESR, CRP up. And then what else do you think will be up from the complete blood? From which other lab would you order? And it would be up as well. Another marker of inflammation. Okay, yeah, you also do a lipid profile, but you're getting there, just cooking. Procalcitonin as well, you order that. That one would be up as well. And then now you talk about your lipid profile, which picture do you expect to see? You might find HDL reduced, LDL high. Yeah. since he consumes a lot of polyunsaturated fats. ECG is a form of imaging. We'll get to that. So labs first. So you do a lipid profile. And then after that, what else do? You do basic metabolic panel, or what we call urea and electrolytes and creatinine. Yeah. You expect them in the acute phases to be, and you just say what I'm saying. In the acute phases, UECs or the basic metabolic panel will be normal. However, as end organ damage ensues, you expect urea to increase, you expect sodium to reduce, and you expect potassium to do something that I want you to go read on, and creatinine to increase. Yeah. And then when you're done, you will say you will do an LFTs, once again, are saying for end organ damage, TFTs to rule out thyrotoxicosis. What else do you think I'll be doing? Then now you talk about your cardiac biomarkers. And you don't just start saying cardiac biomarkers, you start saying cardiac biomarkers being very intentional. Yeah. So you do your troponins. How long do troponins take to peak following a myocardial infarction? Yeah, you could also do glucose for diabetes. And which you do an RBS, it's called an RBS. You do random blood sugar, and it might be high, it might be normal. We don't know. But that one, you just say the way I'm saying. That's exactly how you do it. It's a discussion with the lecturer when you're in that example. So after that, guys, talk to me about cardiac biomarkers. Chandra, which troponins take how long to peak, and how long do they peak for before they go down?
I think troponins were the peak, no, they start rising, I think 12 hours or 6, I can't remember. And then they peak at, okay, I can't remember them, but I know one of them lasts for 7 days and one lasts for 14 days.
Yeah, which one lasts for 15 days?
I think troponin T.
So which one would you check if you want to check for a reinfarction?
Troponin I.
Now we'll check CKMB. You're on the right path. Thank you so much, Andrea. So I want you guys to go and review that. Do an assignment on cardiac biomarkers, and please send it to my email. I'm going through all the assignments at once. So go and read up on cardiac biomarkers, come up with a table that will help you remember how to do cardiac and how long do cardiac markers take to peak. Yeah. So after that, you've done your cardiac biomarkers, which is the most definitive one there. Maybe you can do, because we've talked about syphilis, so the complete blood count could be elevated in somebody who has a syphilitic root. The leukocytes could be elevated in somebody with a syphilitic root aneurysm. And then now we talk about the imaging. Somebody has said ECG. What do you expect to see on ECG? What do you expect to see of ECG that is diagnostically important? AJ, I think that was you, or was it Hirak? One of you. Yeah, Agnes has said ST elevation or depression. Something else I would want to see. What else would I see that's very important to me?
Q waves.
Lovely. Pathological Q waves that are a sign of? Yes, Brenda.
Infarction.
Previous infarction. They've had an MI before. Okay, now we go to echo. What do you expect to see on echo? You guys are doing radiology. Where have you guys reached on radiology?
We haven't started.
Oh. Okay, so on echo, you expect to see wall motion abnormality. Yeah? Do you guys remember the complications of an MI from pathology? Maybe you could highlight a few.
Papillary muscle rupture.
Thank you. Papillary muscle rupture is very important. Another one. Yeah, somebody has said Dressler syndrome. Congestive heart failure. That's amazing. There's something else, because papillary muscle. Yeah.
Arrhythmias.
Yes, arrhythmias. That's awesome. That's all I needed. I needed papillary muscle rupture because that's what we call abnormal wall motion on echo. So they would be seeing the valves are moving out of place because the papillary muscles hold the valves, they control valve movement. You could see that. Ventricular muscle or rupture of the ventricular free wall is also something. So you would see like the heart appear to be shaking on echo. So like normally beats with a rhythm, but you could see one ventricle looking like it's free. In wrestlers, it's something you could tell from history. They have pleurisy or chest pain that is also sharp. They have a fever, and then they have pericarditis. So they also have a chest pain that is relieved by leaning forward. Yeah, congestive heart failure is just heart failure with signs of volume overload. So yeah, what are the complications of hypertension, by the way? And that's why in my history that I have presented, I gave you a guy with increased awareness of the heart rate. And I described this increased awareness of the heart rate as fast and irregular. Fast and irregular. Fast and irregular. Yeah, that's important. Yeah. Any questions so far?
I have a question
Yes, yes,
regarding the history.
yes.
So, when you say the awareness of the heart rate and then it's fast and irregular, do you mention the word palpitations in the HPI or you don't?
You do not. You avoid because for the medical terms, if you want to really see and like decipher them, Hutchison in the first line after giving you the name. So like if it's dyspnea, if you go to how Hutchison describes dyspnea, that will give you how you should put it in your history. And then if you have a patient with, let's say, I'm trying to look for another one that's very common. Like you see palpitations in Hutchison is described as increased awareness of the heartbeat. You don't use palpitations, yeah? I hope that answers your
Yeah.
question. That's
And
okay.
even does that go, is that the same for, like, I was told, but you don't say edema in HPI, you say swelling.
Yes,
Is
yes,
that
yes. Yes. So never, ever mention edema in your history.
okay? Thank you.
Welcome. Any other question? In this history, it doesn't have a review of system, guys. It does not have a review of system. Thank you, Hirak, for that question. It doesn't have a review of systems. Why? Because this is a hypertensive, and hypertension is multi-systemic. So you can't really have a review of system because every system is important. I hope that answers your question.
Hello, can you hear me?
Yes, I can hear you, Yasmin.
Yeah, I just wanted to ask, what
Yes.
if the almost every system is positive? Like there's a positive in almost every system. So how do you go about that?
Thank you so much for asking that question, Yasmin. History taking is communication as much as it is a science, yeah. So can you defend the positivity based on pathophysiology, yeah? You get where I'm going? Like, can you give it a condition? Can you give it a differential? Yeah? Because sometimes these guys will tell you outlandish things, things you've never heard. Like I get a headache when taking a dunk. You are wondering, wow. So what am I thinking? Yeah. I get a headache when I think about money. Those are not your business, yeah? So try and listen to the whole story. That's why I always advise 10 minutes are for the patient. In the 1 hour you'll get in the end of rotation, 60 minutes, 10 minutes, just give this guy. Let this guy speak his heart out and make sense of everything. Yeah. And then once you have made sense of everything, you slowly start to iron out with what you think the pathology could be. I hope that has answered your question, Yasmin.
Still don't know how to put it in my history because like in this case I had something like, I don't want to say an MI, but it was just chest pain relating to the shoulder. And then he was saying also he had abdominal pain. Like at the same time, he had the chest pain, abdominal pain, nausea, vomiting, diarrhea. I was like, I don't know how to put
The
this.
nausea and the vomiting and the abdominal pain, they make sense, by the way. when you will do this system with Professor Gola, he will tell you that and other presentations of SCS. And in women particularly, they normally have that epigastric pain. Then they also have that nausea, that vomiting. That nausea and vomiting is more common in men, by the way. And diarrhea is normally neither here nor there. You know, diarrhea is passage of more than, once again, know the definitions of these things. 300 grams of loose stool per day. So was it 300 grams? Then if it's not, and if it's not speaking to the pathology well, you can omit diarrhea, but you can keep the vomiting because it makes sense. You can cook it in.
Do this like while I'm doing the review of systems in the HPI because it was a case of hypertension, right?
Yes.
Okay, thank you.
Any other question? If there's no question, tomorrow we're still together, same time. And what I want you guys to read on, I want you guys to read on rheumatic heart disease and infective endocarditis. I was supposed to have a session with you guys on Saturday, and you guys didn't show up. Felt very heartbroken, to be honest. We were supposed to talk about the cardiovascular exam, the systemic cardiovascular exam, and I'm going to take it since I wanted to do it physically because online is really not a good thing in that scenario. And I know tomorrow you guys have a booked day of community health, so I won't catch you even if I'm in school. So for tomorrow, read on the cardiovascular exam. We are going to talk about the findings you expect in our patient GR. We're also going to talk about rheumatic heart disease and infective endocarditis. And we're going to talk about the positive findings you expect to find on their exam. And yeah, so we're going to discuss how to do the exam as well. That's why I wanted us to know how to do the exam and I wanted us to meet on Saturday, but that wasn't possible. So guys, schedule a day. I should show you, I have to show you these things physically because they're very important, and the etiquette and the decorum you need as you pre, because you guys are lucky you're doing it the first ones, so that by the time you get to the end of your exams, you're well polished in this area. So, all right, guys, if there's no question, I think we can call it a day.
Thank you.
Thank you so much.
You're
Thank
welcome.
you.
You're welcome, guys.